Hello, this is a review of the material in Chapter 6, which is Anatomy of the Articulation and Resonation Systems. This is the last chapter of our book for this term, so it is important that you understand the material in here. It's also material that probably is most relevant to the day-to-day operation of a speech and language pathologist or a speech and language assistant, because it has a lot to do with voice and the speech sounds, the production of them, and examination of a client or a student's oral structure, those type of things. Often when we are working with a client, we don't delve too deeply into respiration and deep aspects of phonation, but the voice and the speech sounds are very important to our functioning as a speech and language pathologist and SLPA. So the vocal folds are the source of the sound for our phonation, for the voiced phonemes. Without a voice, without that vocal fold vibration, you don't have voiced sounds. And those voiced sounds are then shaped through the vocal cavities. Right? We change the shape of the oral, pharyngeal, and nasal cavities to color our speech a little bit, to create the phonemes of our speech sounds. There's an important theory, which is called the source filter theory of sound production. And basically what it says is that, again, our sounds and our voice are shaped through the use of our articulators. And the vowels, in particular, are produced by three formants. A formant is an energy of different frequency. So there are three formants that shape the production of our vowels. The vocal folds of the sound is very similar to that produced by a trumpet mouthpiece. If you take a mouthpiece off a trumpet and just like that, that's almost the sound that our vocal cords are producing. It is then shaped above the larynx to make our speech sounds and our voice the way we know it. These formants are vocal colorings that are produced by different channels on the human head. Okay? The resonance uses all the cavities and the channels and the passageways and everything that are in our head. In terms of the three formants that we pay attention to most, the first one depends on the length of the vocal tract. In other words, from the larynx up to the outside of the mouth, the length of that. The second formant depends on the place of articulation, where the speech sound is actually sort of molded. And the third one appears to be in the back region of the oral area, back in the pharyngeal area. So it adds some color, but it doesn't necessarily give you a true individual character to your speech. The articulators, commonly we know the elements of our anatomy, speech anatomy that produce different sounds are called the articulators. And we use those structures to move them and to form the different speech sounds. Those articulators include the lips, the tongue, the soft palate, the mandible, and the teeth. Now, hard palate, some people consider a hard palate to be an articulator. Other people do not. We will include it in our list, but probably much more important is the soft palate. Vowels, the place of articulation, the positioning of the vowel moves back in the vocal tract. Formant 2 decreases in frequency, so the sound gets a little bit lower for a vowel. As we move the tongue back and forth in the oral cavity, we change the nature of the vowels. So a lot of our vowels are determined by tongue movement. Consonants sort of follow the same path, but consonants are a little bit different. Vowels, you don't have to be really precise. Ah versus ah. Those actually are two different sounds, but they're very close. You would never notice the difference. Okay? Consonants, though, there is a bit of play in some of the consonants. There's a little bit of variation. So whether my tongue tip is in the exact same position that your tongue tip is in when I'm making a T or a D, there can be some variations. Also, when I produce a T sound in one word versus another word, there might be a little variation in the placement of the tongue tip. However, to you, the listener, it sounds like very much a similar T sound. There are some sounds, the fricatives, which are F, V, S, and Z, and affricates, such as ch and je, are very sensitive, however, to the placement of the articulators. So a little difference in movement for those sounds can produce a different type of perception of the sound itself. On page 2, make sure you know examples of some of those different types of location of the articulators and the speech sounds that are created with them. For example, bilabial, bi meaning two, labial meaning lips. The two lips come together. An example of that would be B or M. Okay. Labiodental is the lower lip and the teeth for F and V. Dental is the tongue tip to the upper teeth, so that would be a TH and like this or thin. Alveolar, the tongue tip to the alveolar ridge. The alveolar ridge is a ridge where your teeth sort of are held in. T, D, N, S, Z, L, those are all sounds produced in that area. Palatal is where the tongue blade approaches the hard palate. R and S, H, sh, doesn't actually touch. Because if I was to touch the hard palate, it wouldn't be sh, it would be ch. All right, and velar, the tongue tip contacts the velum, which is the back part of your palate. It's the soft palate area. So K, G, and the ing sound. And then finally, glottal. If you remember, glottal, it does not require vocal cord vibration. So the H sound is a glottal. So no examples of those. Our head acts as a filter for our speech sounds. So included in those structures that filter our speech sounds are the bones of our face and skull, the cavities in our skull, the open spaces, the face muscles, your teeth, the tongue and velum muscles, right? The velum is the soft palate again, and function for speech and swallowing. So all those things play a role in our speech production. The mandible is the lower jaw. It's massive. It's one of the strongest bones in the body. Not the strongest bone, but it's one of the strongest bones. And it contains or houses the lower teeth. All right, it's your lower jaw. It begins in formation in a fetus. It begins as two bones that come together and fuse in the middle. The maxilla, or actually there's one maxilla, there's two maxillae. They are the second largest bones of your face. During fetal development, again, there are two sides, two parts of it. They come together and fuse in the middle. For most humans, forms the upper part of the jaw, the roof of the mouth, the floor of the nasal cavity, the walls of the nasal cavity, and part of your eye socket. So that's the maxilla. It's very important. The hard palate on page 3, the hard palate forms the floor of the naval cavities and the roof of the mouth cavity area. All right. If you look at worksheet 22, I believe it is, there's a more detailed view of the oral structures. So pay attention to that worksheet. A cleft palate is where those two structures that are coming together in the roof of your mouth, for some reason, they do not come together the right way. Either there's a small hole, even though you can't see it externally, but there's a small hole in the palate, or there might be a cleft in the back part of the palate, the soft area, the velum, or there may be a cleft or division all the way from the soft palate right up to the front of the hard palate, and maybe even extending out through the lips. So a cleft palate is where there's a weakness, a hole, or a split in the roof of the mouth. And in your PowerPoint, you see an example of some cleft palates. The nasal bones, they're small bones. As a group, we just call them nasal bones. I'm not so concerned that you learn all of them, but nasal bones are there. They're very important. Some of the bones that we want to look at are the vomer, which is part of the nasal septum. The septum is that middle part of your nose area. Septum means separation. It divides the two nasal cavities, the left side, right side of your nose area. It's an unpaired bone that extends up right through the center of the nasal area, the vomer. The zygomatic bone, or it's the side of and floor of the orbit where your eye is, but I'm most concerned about the zygomatic arch, okay? The zygomatic arch, think of it as the point of your cheekbones, all right here. That's the zygomatic arch. Those are important to some of our speech movements. The areas in the brain case, in other words, the top of your skull here, there are bones there, the ethmoid, sphenoid, frontal, parietal, occipital, and temporal. There's just a few that I want to highlight for you. We talk about one structure there that's called the nasal conchae. These are connecting tubes and chambers in the skull, all right, in the nasal area, the nasal conchae. They help to warm the air before it goes down your throat and into your lungs, okay? If you've ever had a brain freeze, the reason you get a brain freeze is because the air going to that region, either the air or maybe the bones themselves, are super cold, and the pain receptors in your nasal area get stimulated, and that's why you get a brain freeze. And the best way to get rid of a brain freeze is to take away whatever was so cold, but also breathe air in back and forth. That will help you get rid of a brain freeze. So the nasal conchae, they help take care of that to warm the air coming into the nasal area before it reaches the lungs. The sphenoid bone is sort of a butterfly-shaped bone. Okay, it makes up the bulk of the cranial cavity. And then the upper skull, the top of your skull, that we can, well, you can't see it, but if you look at a skeleton, you can see these bones. The frontal bone is up front, okay, ergo the name. It's an unpaired bone. It's the one big bone in front of your skull, okay? It's above your eyes. The parietal bones are in the back top part of your skull. There are two of them. The occipital bone is in the base of your skull. There's just one, the lower area of your back skull. This protects the visual area of your brain. The temporal bone is the lower area of the skull behind your ears, okay, over in this region. It's very hard. It contains the mastoid process and the styloid process. And that is where the external ear canal, otherwise known as the auditory meatus, extends through this bone. So your ear canal sort of works through that. So when you stick your finger in your ear, you're coming in contact with the temporal bone. The cavities of the vocal tract, the buccal cavities are cheeks. Remember we talked earlier in the course about buccal means cheek area. The oral area is the main area. Pharyngeal is the back of your throat. And then the nasal area is your nose. The buccal cavity is has the lips and the cheeks, all right, the gums and the teeth. That area is often covered up by the teeth as you're talking, but it still helps to resonate. The pharyngeal cavity, and you notice it says it's about 12 centimeters long. That's about 4 or 5 inches long. So the back part of your throat, the top of your throat that you can see down to the area of your vocal cords, that's about 4 inches long. Connects the back of the nasal cavities with the stomach and the lungs. The other area you should know about is the auditory or eustachian tube. This is a bone canal that goes from your middle ear and extends to the back of your mouth. So in babies, the eustachian tubes are flat. So that's why babies oftentimes get ear infections, because the purpose of the eustachian tube is to drain excess fluid out of the middle ear. And if they're flat, there's not a lot of drainage going on. So babies are much more susceptible to ear infections. As we get older, the eustachian tubes sort of begin to bend down a little bit or aim down so that they're draining into the back of your pharyngeal area. This is, if you've ever had your ears pop, that's because that tube, eustachian tube, is opening up enough so that air pressure could be equalized. If you remember, I think the introduction video I presented to you folks and talked about, there's not a lot that I remember from my anatomy and physiology class from 50 years ago. There is some. But one name that just stuck in my mind was the salpingopharyngeus muscle. And what that muscle does is when it constricts, it sort of opens up that tube a little bit more. And it's very influential when you're swallowing, and laterally draws the pharynx walls up, so it allows that pressure to equalize. It allows you to help with your popping of your ears. Then muscles of the face. There are a lot of muscles on the face, but there are just a few that I want you to focus in on. The orbicularis oris is the sphincter muscle around the mouth, right? So when you're puckering, like kissing, that is the muscle that does that. Buccinator is a muscle that pulls back the cheeks and flattens them, all right? It's a cheek muscle. The risorius is at the corner of your mouth, corner of your lips, and it pulls the lips towards the teeth. The zygomatic major is outside the eye socket area, down to the lips. It draws the lips down, okay? It draws the lips up, and it makes you grin. The zygomatic major muscle draws the angle of the lips up and allows you to grin, okay? There's another muscle that allows you to pout or frown, but not too worried about that right now. So the articulators, again, middle of page 6, the lips, the teeth, the tongue, the hard palate, and the soft palate, the cheeks, and the mandible. Mandible is the lower jaw. They are all articulators. So now into more detail for some of these. The lips are important. I'm not going to require you to know everything there is to know about the lips, but a couple things. One, the philtrum is the groove in the center. Okay? The labial frenulum or frenum is a little arch of skin that goes from your upper teeth to the inside of your upper lip. There's also one on the bottom, from the bottom of your tongue to your jaw. The top one, the top labial frenulum, is not that important. It's not usually a bother. The bottom one can be a problem in that if that tie there is too tight or too thick, it will restrict the movement of the tongue tip. So some kids have what we call a tongue tie, or the technical term is ankyloglossia. And what it means is that they just have restricted tongue movement because of that frenum or the frenulum. So a lot of times what they do is they perform a little bit of surgery just to clip it completely or to clip it a little bit to free up the movement of it. Okay. Talk about dentition. The crown of your teeth is the visible part. All right, 1/3 of your tooth. The root is embedded in the alveolar process. That's 2/3 of your tooth. Cementum is a thin layer of bone holding the tooth together. The dentin is the ivory sort of your tooth. It's the bulk of your tooth. It contains the nerves in there in dentin. And enamel is the hardest substance in your body. The enamel of your teeth is the hardest substance you have in your body. It covers the crown to the root. It's not on the root itself, but it goes from the crown to the root. It resists abrasion, and it's thickest on the grinding surfaces, and it's because that's where you chew, so you want a real hard surface to do so. When you get a cavity, there has been some erosion or a problem where there's been a hole in that enamel. Children have teeth, obviously. Adults have a different number of teeth. So children, when they have all their primary teeth in, there are 20 of them. Adults, when they have their complete set of what we call secondary teeth, there are 32 of those. Many times people will lose some, they'll have their wisdom teeth taken out or whatever. But children have 20 teeth, permanent teeth, and primary teeth, and adults have 32 secondary teeth, permanent teeth. When do they erupt? Children's teeth start coming, the central incisors, the middle ones, they start coming in about 6 to 9 months of age. Right? That's when a child, they call it teething. That's when they first begin to get their teeth. Most children start growing their permanent teeth by about 6 to 8 years. Some of them, the initial ones, will fall out and the permanent teeth begin to descend and move in. Most adults have their full set of permanent teeth by the age of 25. So those are the landmarks. Types of teeth. Don't go crazy over this, but I do want you to know that your incisors, particularly your central incisors in the middle, are the teeth that you use to chew and to bite with. Okay, so you chew off a piece of meat and you use it to cut with. So biting and chopping. The canines are more what we call the eye teeth. Premolars, a little bit further back, they have 2 cusps, points on them. And then your molars are your largest teeth, and they are what are used primarily for chewing. The major chewing motions of our jaws are done by the molars. There are 4 basic steps in tooth development. There's the development or growth period where the teeth are just forming. Then there's a period of calcification where they're getting hard. The little tooth buds are getting hard. Then they begin to erupt or show. And then attrition means that they begin to fall away. The growth period begins 5 weeks into the development of an embryo. So your teeth are beginning to form 5 weeks after conception. Enamel begins to form and dentin begins to form in the 7th week. So eventually enamel and dentin are hardened by introduction of calcium. This is why it's very important that pregnant mothers get a sufficient amount of calcium. And then eruption, the teeth come through the alveolar process, the sort of ridge of your jaw where the teeth are. Calcification is still occurring. The bony tissue between the teeth begins to ossify or turn to bone to form alveoli. Now, this use of alveoli means holes in your teeth area, where the teeth go into. All right, different than the alveoli in your lung. The teeth migrate into that oral cavity, and a person starts getting their baby teeth 6 to 9 months. The eruption of the baby teeth finishes by the end of the 2nd year, and then again, about 6 to 8 years of age, the child starts to shed their baby teeth. Attrition means losing permanent teeth. All right, this can be the result of wear and tear, pressure, strain, wearing away of the enamel. Premature attrition can result from chewing ice, something hard, smoking. Bruxism is grinding of the teeth. Usually the wear is on the top portion of your molars, okay? But it can also happen between teeth sometimes too, especially if they touch and rub back and forth. We talk about occlusions. Now, occlusion just means the relationship between the arches, okay? Your lower arch, that circular thing with the teeth in it, and your upper arch, okay? The relationship. It should be of a certain type. It should be all in line, and you should be able to perform reasonably good biting and chewing with proper occlusion, okay? If it's out of alignment, it's called a malocclusion. And if you have, sometimes a kid will, when they swallow, normally when we swallow, we don't protrude our tongue out, okay? But sometimes children, especially when they're developing, they swallow. It's sort of an offshoot of the sucking motion, but they swallow and they push their tongue forward. And you do that, 100 times a day, it begins to move the teeth, especially when the teeth are forming or growing. It moves the teeth out of their proper position, and you get what's called a malocclusion. And if you get a severe case of that, where the child is really pushing out the tongue every time he or she swallows, then we need to institute something called myofunctional therapy, orofacial myofunctional therapy. And what that is sort of retraining the child to use their tongue so that they don't protrude their tongue when they swallow. You do not, if the teeth are in the first set of teeth and there's a malocclusion because of tongue thrust, usually you try to get rid of it before the permanent teeth start to come in, because if the permanent teeth are maloccluded because of tongue thrust, then eventually you're going to need braces. Just a few terms related to tongue orientation. You see them in your notes on the bottom of page 8, so just know those terms, okay? I think the most important ones to know are distoversion, whether it's a tilting away from the incisors, a labioversion, tilting towards the lips, linguaversion, tilting towards the tongue. Infraversion is where the teeth have not erupted enough, so there's not good closure for chewing. And a supraversion is where a tooth or teeth have erupted almost too much, so it makes chewing difficult. Okay, so those are the most important. Parts of the tongue. The tip, you know, is the very tip of your tongue. Okay, the blade is right behind the tip. It's the front broad part of your tongue. The dorsum is below the hard palate, a little bit further back. It's the broad part in the back area of your tongue. And then the root of your tongue is like the very base structure of your tongue. The strongest muscles are down there. Some muscles of the tongue. Just sort of get a feeling for what different muscles of the tongue do. So the superior and the inferior longitudinal muscles, they are the long muscles, and when they contract, it's going to shorten your tongue, all right? The transverse muscle are the muscles that go across your tongue, and so when they contract, it's going to narrow and sort of push out, elongating the tongue, but make the tongue narrower. And the vertical muscles of your tongue, they sort of think of them as the muscles that are most concerned with like the thickness of your tongue. When they contract, it's going to flatten the tongue. All right. There on bottom of page 9, there's a review of the major actions. For example, you know, the tongue, if you want to lengthen the tongue and narrow it, you would use the transverse muscle. So just refer to those. A couple other muscles of the tongue, particularly as they relate to mastication or chewing. The masseter goes from the zygomatic arch, the cheekbone, down to the angle of your mandible. So it's like right here. And it elevates the mandible. It pulls your mandible up during chewing. The temporalis is a muscle that is up here and goes down the side of your skull and then sort of dips in and gets to the mandible. And that's going to elevate the mandible quickly. A couple other muscles are there. The geniohyoid muscle depresses the mandible, all right? Geniohyoid attacks to the hyoid bone, the lower jaw. When that contracts, it depresses the mandible. The mylohyoid, we've talked about that one before. The side of the lower jaw down to the side of the hyoid bone. It depresses the mandible, but it also forms the floor of the oral cavity, the muscular area. So it's a major muscle that forms the floor of your oral muscle area. Always remember that the soft palate, another name for that is the velum. That's that muscle in the back of your palate, okay, attached to your uvula. There are some pharyngeal constrictors that are important to the resonance of our voice. The pharynx is the back part of your throat, okay? And the constrictors tend to close that area down a little bit, make it thinner, make that tube thinner. Esophageal constrictors, that's esophagus, is the tube that goes down to your throat. Goes down to your stomach. And that can constrict a little bit too and change the sound that's produced from your larynx. Very important little assessment is something that's called diadochokinetic rate, okay, or diadochokinesis. And what that means is you have the person say a rapidly alternating group of syllables, okay? Pa is a front sound, pa. Ka is a back sound, and ta is a sort of middle inside your teeth. Padaka, 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 padaka. And you try to ask them to say that as many times as they can in 30 seconds or a minute, okay? And you count them, all right? For example, I put in the notes, say padaka, padaka, padaka rapidly as many times as you can in 10 seconds. And you count that, and then you look up some charts and you find out whether the speed is abnormal in any way. There's a lot of variation in this. Some people are just slow talkers. So when you say padaka as fast as you can, they're just not going to do it really fast. It doesn't mean there's any neurological problem. It doesn't mean there's any issues going on. It just means they're slow talkers. The clinical implication for this, though, is slow or inconsistent diadochokinetic rate suggests that there may be something that's wrong. So you got to look into it a little bit further. But it doesn't always mean a disorder. But it can give you some insight into the neurological functioning of the client. So the diadochokinetic rate, or diadochokinesis, is very, very important. And then we often do in speech and language and hearing, we do something called an oral peripheral exam. Oral meaning mouth structure, peripheral meaning all the different parts and the sides. Assessment of the oral and speech structures to assess the health condition and function of the basic speech structures, all right? There is a handout that I put into Moodle that you can look over. But key elements include assessing if a person can grin, pucker, frown, puff out the cheeks, lateralize the tongue, and then also produce a certain number of words to produce a variety of different speech sounds. So they look at the facial structure, the mouth area, being able to puff out the cheeks and lateralize the tongue. These are all important things. And if the kid, just do a quick screening on these things. It takes 2 minutes. And if everything's good, then probably the child can produce reasonably good speech. If there are problems with that, if the child cannot blow out their cheeks and maintain it, then that might be a problem with the soft palate, for example, the velar. All right. How do our voices change with age? There's a very good video that I put onto the PowerPoint, so you can look at that. Okay. There is no quiz per se this week for this chapter, but this material is going to be on your final exam. So part A of your final exam has to do with chapter 6 and only chapter 6. So in essence, it's like a quiz, only it's worth more points. Okay, so it's very important that you study this material well. The whole use of the articulators is very, very important part of your future career. So part A of the final exam is going to be chapter 6, and part B is going to be a short essay, probably no more than 300 words, that you need to respond to a question that will help you summarize things that you learned in chapters 1 through 6. Okay? As always, if you have questions, if there are problems, if I've screwed up on something, or if you need clarification at some point, please send me an email, and I'll be happy to help you out as much as I can. So, thank you very much.